Hello, everybody. Welcome to February's monthly training. We're going to be going over management of chest trauma. We're going to go over the two most common mechanisms, blunt and penetrating, the injuries that are associated with them, the mechanisms of injury, and then common treatments with a little main EMS protocol review as well. So we'll get right into it. So blunt chest trauma. We're most commonly seeing this from motor vehicle collisions. This is going to be the people who take the airbag to the chest, back of a seat, steering wheel. Um, there are many risk factors for serious injuries, and a lot of these are um, pretty self-explanatory. Traveling at a high rate of speed, not using a seat belt. If we see extensive vehicle damage on arrival, that might be a good indicator of a serious injury. And steering wheel deformity. Common injuries we're going to see from these MVCs when we talk about blunt chest trauma is going to be rib fractures. If you have one or two minor rib fractures, it could lead to a pneumothorax. Obviously, something that needs to be taken care of. But if someone has multiple fractured ribs, whether or not it's technically a flail segment, that is a serious injury. Other injuries are blunt aortic injuries in cardiac and pulmonary, which we'll go over on the next slide. Something you're going to see between blunt and penetrating chest trauma, there's only so many things that we can do in the field. So managing our ABCs is going to be highly important, especially where, breathing and circulation could be impaired from blunt chest trauma. That's something that we need to address to the best of our ability. So blunt aortic cardiac pulmonary injuries. So blunt aortic injuries are blunt chest trauma that results in immediate death. Um, there's a few risk factors that this is going to be more common. If you're over the age of 60, front seat occupancy, and seatbelt non-use. So this kind of all adds up, uh, especially if it's a front-end collision, taking a blunt. Most of that mechanism and speed of the crash to the chest. If you're a little bit older, you don't have as much protection there. Your bones aren't as strong. And then obviously seatbelt non-use, you're not having anything stop you from going full force into a steering wheel or airbag. So this is an aortic injury that basically severs and you bleed out immediately. Blunt cardiac and pulmonary injuries are also common. Um, you can see pneumothoraxes, like we talked about with rib fractures, pulmonary contusions or myocardial contusions, just basically bruising on the lung or the heart tissue, all gonna be chest pain essentially. You can also have commotio cordis, not common in like motor vehicle accidents. This is more of like those youth sports scenarios talked about in class where someone gets hit in the chest, or maybe it's in more of a assault or fight setting rather than a motor vehicle accident. But blunt chest trauma can cause commotion cordis, which would cause sudden cardiac arrest. Penetrating chest trauma. So these are what we're going to see from most commonly gunshots and stabbings, but you can also have industrial accidents, falls, blast injuries. Uh, They just need something to actually penetrate the chest rather than just make contact with it. Um, Pretty self-explanatory what your injuries are going to be from this. Stab wounds, gunshot wounds, and sucking chest wounds are your most common. Um, any penetrating injury to the cardiac box, which we'll go over on the next slide, is going to have a high risk of injury to the heart. It'll make a little more sense with the diagram. Again, management of ABCs is highly important in these patients. Cardiac box. So this area, ignore all these little dots on it. It's the best illustration I could find, is where you're most vulnerable to have damage to the heart, the vasculature, the mediastinum, and that could be basically very fatal for the patient if they experience an injury to this box. So it's right under um, your clavicles, but basically about a sternal notch up top. goes down to about your xiphoid process, and then it's either marked by your midclavicular or nipple line. Um, any penetrating injury to this box could have very severe consequences, even if it's minor, just because of how much vasculature and how close it is superficial to the skin. Um, really not a place where you want to be suffering penetrating injuries to. So if you have any penetrating injuries to this area, eh, more often than not, the patient's probably not going to be very stable, or it's going to be very critical appearing right out of the gate. But this is a crucial finding. We're going to start going through some of these injuries and their treatments. So first one we're going to go through is a pneumothorax versus a tension pneumothorax. So pneumothorax is just air in the pleural space. This isn't always going to be a um, traumatic cause for a pneumothorax, but it is something that is commonly seen when you have chest trauma. So you have air into the pleural space. It's not all in the lung now. The mediastinum is not shifted or only slightly shifted. Most common symptoms are going to be sudden shortness of breath, sharp chest pain. They sometimes describe it as pleuritic chest pain. You won't have absent lung sounds with just a simple pneumothorax, um, but they'll be decreased. You're not going to decompress a pneumothorax. We're going to wait for it to develop into tension, or they don't all develop into tension, um, but you do need to wait for it to develop into tension to decompress. So a tension pneumothorax is the life-threatening progression of a pneumo. Sometimes these things can heal their own. If it's not a big pneumo, will make a little more sense on the diagram on the next slide. But if the leak is continuous, it's going to build more pressure into the chest. This is going to shift the mediastinum. It's basically going to push your heart towards the other lung. You're going to take all this area away that it had to freely flow and compress it into other organs. This is going to impair venous return to the heart. So you're going to have severe respiratory distress, hypotension, distended neck veins, absent lung sounds. Um, they teach you a lot about tracheal deviation in school with this. This is a very, very late finding, and not going to be a great outcome for the patient if we're seeing tracheal deviation. Needle decompression is not only appropriate with these patients, but it's life-saving until further definitive care, which would be a chest tube, could be placed in the emergency room. We'll go a little bit more into the procedure of needle decompression at the end of the presentation. So, tension pneumothorax and the big difference between pneumo, it basically worsens, you build more pressure, and we're now limiting the heart's ability to pump blood. So we have to reverse that by helping get that air out and releasing the tension in the chest. See, this is a good little diagram that kind of shows a bunch of different, well, not a bunch, but a simple pneumothorax tension open. Over here on the left-hand side, you're going to have how the lung should normally look. Here's going to be an open, so this would be a penetrating chest wound, basically where not only did you could have basically a pneumo from the lung itself, but also from a hole in the chest that's allowing a rush of air in that's compressing the lung. So in these cases, the lung doesn't necessarily have to collapse um, from an injury to itself, but it's more this air coming in here is going to cause the lung to collapse. Closed pneumothorax, this could be like a rib getting it. People have blebs on their lungs that pop, and that's how the air releases into the pleural space. That would be a non-traumatic cause. But again, you can see the lung collapses, air is in the pleural space, but nothing really shifted here. Tension is where you have this collapsed lung, it's building pressure, and now you're seeing this is where you'd see some tracheal deviation, but the mediastinum shifts and the heart is being compressed into the other lung. That's where you're going to have that hypotension, worsening respiratory distress appear. Cardiac tamponade. So this is where the pericardial sac is damaged and begins to fill up with blood. So it's going to prevent the heart from squeezing effectively, both filling and squeezing out to the body. This fluid that builds up around in the pericardial sac essentially is going to limit the heart from fully functioning to the best of its ability. More commonly seen in penetrating injuries, um, but signs and symptoms: hypotension, shortness of breath, chest pain, tachycardia, distended neck veins, feeling anxious, dizzy, faint. Beck's triad, this is the big one you learn in school, is a crucial finding. Hypotension, JVD, that's your distended neck veins, and muffled heart sounds. A lot of the symptoms that you see here, the hypotension, shortness of breath, chest pain, tachycardia, you will also see in a pneumothorax or a tension pneumothorax, but the muffled heart sounds, uh, JVD maybe would be your kind of differentiating factor there, and you probably wouldn't have any lack of lung sounds like you would with a pneumo to differentiate between cardiac tamponade and the pneumothorax. We really can't do a whole lot for this pre-hospitally other than we're going to support the blood pressure. Obviously, you don't want to load them up with fluids and worsen the entire problem, but you do need to keep that blood pressure at a good enough number to keep them awake and perfusing. They'd get pericardiocentesis, which they're basically just drain fluid out of the pericardium, repair it. And that's going to be done in the hospital. So this is more of a you need to recognize we're going to support the blood pressure. We're going to go fast to a trauma center. Subcutaneous emphysema. So this is when a traumatic injury causes a tear in an air-containing structure that allows air to escape. So this is more commonly seen in the neck or chest, though it can occur in the face. If it does, you'll see people with very swollen eyelids. But again, this is more commonly we're going to see that in the neck or the chest. You're going to feel, and you wouldn't hear, but more feel that crackling or popping sensation when you touch it. So people would describe it as like Rice Krispies. Think about like, your clavicles and kind of the upper part of your chest. That would be a good spot where you might find some subcutaneous emphysema. This basically just is going to indicate to you that there's an underlying injury that could be serious. This is maybe a pneumo that is beginning to release air, and that's why you're starting to feel that subcutaneous emphysema now. Um, Definitely a finding that you want to report to the hospital, and it's going to warrant further investigation and a really good assessment of whatever area you are finding that subcutaneous emphysema in. Rib fractures and flail segments. So, commonly seen in blunt trauma, definitely a lot easier to occur in elderly patients. We talked about this earlier, but rib fractures can cause pneumothorax. They can puncture organs and cause other internal injuries. Just think about a sharp bone fragment that is basically out of control. It can just stab and poke a lot of things that it really shouldn't be. We define a flail segment as three or more consecutive ribs fractured in two or more places. Obviously, an X-ray is going to definitively diagnose that, but if you feel someone's ribs and you're going down, and there's a lot of crackling, popping, a lot of pain, you could have a high index of suspicion that they may have a flail segment. I think a lot of people have seen that video of someone on a fishing boat where you kind of have that really awkward, paradoxical chest movement from the flail segment where it's basically doing the opposite of what it should be. Um, they used to say in school, like to splint the chest, kind of fallen out of practice. They might not be able, they're gonna have some impaired breathing if they have a flail segment, and that's where you're gonna assist with BVM ventilations if you have to. Um, but for rib fractures and flail segments, a lot of this is pain control, ABCs, and definitive treatment's gonna be in ER. So signs and symptoms: sharp chest pain or chest wall pain. It's going to worsen with breathing or coughing. They're not going to be able to take a nice deep breath in, so they'll be breathing shallow. Um, and then obviously some bruising or chest wall deformities, very obvious external injury if you have a rib fracture. Open chest wounds and chest seals. So, open chest wound or open wound of the chest area is allowing movement of air out or moving air into that very defined space. This causes air in the pleural space to collapse the lung. It can quickly lead to a tension pneumothorax if it's left untreated. So, you're going to put the chest seal on, covering whatever hole is there. And if you see this little tab at the end, I believe this is what we carry. Um, this is how you would burp the dressing if they begin to develop the signs of tension pneumothorax. So that's increasing respiratory distress, hypotension, increased pain. Um, Remember that that hole may have let some air out, so you're now all this extra air has come in through this wound, and then you seal it. It's going to be too much for the chest to handle, and it's going to cause that tension to occur. So that's when you're going to burp it um, with this. If you don't have a chest seal that has a little tab to burp it, that's where you take your whatever occlusive dressing you're using, tape it on three sides, so you have that fourth side available to release tension if it develops. The last procedure we're going to go over is needle decompression. Um, This is in Green 7 chest trauma protocol, and we're going to perform needle decompressions in all suspected cases of tension pneumothorax. So the main EMS protocol defines assume intention as in all traumatic arrests, chest trauma with respiratory distress or hypoxia, and chest trauma with otherwise unexplained shock or hypotension. So I know they've been pounding on this a little bit over the last year. There's a lot of providers who were maybe performing this procedure prematurely, but it needs to meet some of this criteria. So we have two spots, and we'll have a little diagram on the next slide where we can perform this chest decompression. We prefer to perform it in the fourth or fifth intercostal space on the anterior axillary line, uh, but if you have to, you can do the second or third intercostal space on the midclavicular line. The reason why they like the anterior axillary line better because it has a much lower failure rate, so it's more successful in a patient that if they need needle decompression, it's a very critical patient, and this is a very critical intervention to prevent cardiac arrest. You may need to repeat this procedure. Either there could, if it's a hemothorax where there's blood also in the chest cavity, that might clog up your decompression. So you'd have to decompress again. You're not gonna remove your other attempts. You're gonna keep them in. You would just repeat um, in the same area, but you obviously have a few options of where you're gonna go. So again, a midclavicular line, second or third intercostal space. Then we have our anterior axillary line. We have one, two, three, your fourth or fifth on that line. So those are our two sites where we can decompress the chest. Thank you for watching. If you have any questions, as always, just reach out. But that is all we have for now.